Dr. Mukesh Mehra to felicitate the dignitaries. For the next session, I would like to call on stage our moderator, Dr. Ajay Kumar Gupta, and the panelists, Dr. Manoj Singhal, Dr. Ravi Bansal, Dr. Naresh Dang, Dr. Rajeev Bansal, on the stage, please. And Dr. Setu Gupta, sorry.
So good evening everyone, and today like we have been discussing about the diabetes and the kidney diseases. So now we'll be having a panel, though means many of the questions which I had formulated have already been discussed in the previous talks, and many of the questions were answered by Dr. Kullar and Dr. Manish, but I still have some confusions. I don't know, means many of my friends may be also having such confusions. So I would like my eminent panelists to answer and kindly guide us. So sir, like what we talk like we talk commonly, CKD and DKD, chronic kidney disease and diabetic kidney disease. So sir, my first question will be to Dr. Manoj Singhal, that is there a particular difference between a diabetic kidney disease and CKD, or why have we, if there is no difference, then why do we have two different names? And one more thing means, is there a particular physiology in diabetics which lead to the kidney disease? And if yes, then are there any stages in which we can see or find it out, sir?
I think there is a change in nomenclature. So, for example, CKD and DKD is just that if the diabetes is the cause of chronic kidney disease, we call it diabetic kidney disease. Earlier, we used to use diabetic nephropathy as a generic term for kidney disease in diabetes. But that predominantly refers to glomerular changes related to diabetes. And traditionally, it has been a teaching that there is a stages of stage 1 like hyperfiltration, then mesangial expansion, decline in GFR, and advanced stage of kidney disease, which correlates with the diabetic glomerular changes, for example, mesangial hypertrophy and expansion of mesangial matrix, and gradually there is glomerulosclerosis and advancing renal failure. Clinical counterpart of that was proteinuria or albuminuria, which we now know that moderately increased or severely increased albuminuria. In early stages, there is microalbuminuria or moderately increased albuminuria, and then macroalbuminuria, and then declining GFR. But now there is a change in phenotype. So we see many patients who will not follow this typical pattern of kidney injury. We see more of non-albuminuric diabetic kidney disease. Almost 30% patients who have diabetes will never develop albuminuria, and they will have directly decline in GFR and progressive glomerulosclerosis. Probably there are different type of pathogenic mechanisms. So patients who have non-albuminuric diabetic kidney disease, they have predominantly interstitial and vascular changes. So a pathophysiology may be more like a hypertensive type of nephropathy or ischemic renal disease, which predominate in these patients, that lead to predominantly interstitial fibrosis and tubular atrophy. And then along with that, there is glomerulosclerosis, which later on comes. So they do not develop albuminuria and directly have declining GFR and land up in end-stage kidney disease. So if we just target glomerular changes or keep looking for albuminuria, we might miss these component of patients, which is almost 1/3 now. So that's why there is a change in nomenclature. So we call it diabetic kidney disease. So any kidney disease related to diabetes, whether it is a glomerulopathy, whether it is a tubular interstitial disease or vascular disease in diabetes.
So it means the old teaching, like it was said, that whenever you find a patient of diabetes with nephropathy, then you should always look for retinopathy, and if the retinopathy is there, then only it is diabetic nephropathy or diabetic kidney disease. So does that still stay, sir? Or
yeah, that correlation is good for patients who have type 1 diabetes. So almost 90% patients will have microangiopathy, so they will have retinopathy, they will have neuropathy and diabetic glomerular disease. In patients who have type 2 diabetes, we know that the correlation is not that good. So only 2/3 patient will have retinopathy. So 1/3 will have more of a changes related to other pathophysiological mechanism like hypertension damage probably will be more marked in these patients, or many other like repeated sort AKI or other pathogenic mechanism which may lead to diabetic kidney disease. So this correlation is not good in type 2 diabetes.
Thank you very much, sir. So my next question to Dr. Dang, sir. Sir, you are a eminent diabetologist in this area and you are dealing with so many of diabetes patients. So what in your opinion or what in your understanding is the main cause of the progression of the DKD or the DKD diagnosis in our patients? Like whenever we are seeing a diabetic patient, so we always say that you should go for the urine albumin creatinine ratio. So what in your experience is the predisposing problems or predisposing conditions for the for this diagnosis, sir?
So India is, that way our control of diabetes is dismal. We have very bad control of sugars. We have associated hypertension, which also is uncontrolled in our patients. Statins are also used less. As Dr. Kula was saying, statins are the next aspirin, but I think a lot of inertia on the part of the physician, lack of education on the part of the patient, and everything comes 10 years, 12 years earlier. So one is that we must give good glucose control and use the therapies which will have pleiotropic benefits. So using SGLT2 inhibitors earlier on, GLP-1 receptor agonists earlier on, all our diabetic patients are obese. Most of them are obese and have, so obese, renal issues, heart failure with preserved ejection fraction, the CKM syndrome, and everything is going on together. And our patients are walking time bombs. And it gives me jitters, honestly. I see them, and we have limited time. You do try to explain them and they don't understand. And if you really want to explain to them, actually it will take 1 hour and then maybe patient will run away. He'll say, "Ki main kahan aa gaya, mere ko to doctor ne dara diya." So poor glucose control, not doing urine for ACR in most of our patients. We should be doing urine for ACR in all our diabetic patients at diagnosis, at presentation. Today I had 3 patients from same family in the morning. All 3. One of the parents had urine for ACR which was 150-200. Son who was never taking any anti-diabetic also had 300 urine ACR, and so we must do it for all our patients. And we need a very holistic approach, and I hope we are able to do it. Our load is more and we have less time.
Thank you, sir, for these comments, because we all feel means like we are facing or we are heading towards becoming the diabetes capital of the world with nearly 11 million of diabetic patients and the similar amount in the pre-diabetic stage. So, Dr. Ravi, like what Dr. Dang has said, the inertia is the most important problem, means whether it is from the patient side or whether it is from the physician side. So, how can you, means what is your opinion to guide us? Like Dr. Manish said that many of the patients from 30 to 60 will come to the physicians only and will not go to the nephrologist. So how do you think we physicians can this progression, or we can arrest this progression, or we can diagnose it early? So what are the early diagnostic signs for a DKD for us physicians' knowledge, sir?
So diabetes, when it starts involving the kidney, signs could be pedal edema, signs could be hypertension, but signs may occur very late. So screening is important. So patients who are at high risk of kidney disease should be screened, and diabetes is a high risk group. So as Dr. has mentioned, at initial first contact, you should screen the patient for end organ microvascular, macrovascular complications of diabetes, which would definitely include a urine MACR. But I would also like to emphasize use of urine routine. So urine routine is very important, because as physician, our role should be to rule out non-diabetic renal disease in a diabetic patient. So every diabetic patient who has a renal disease, maybe they are having non-diabetic renal disease. So that should be very important, and urine routine will help us in seeing if there are WBCs or RBCs in the urine. So I would like to do it at first contact. So this should be like screening, which will help us in the early diagnosis.
So it is very important to go for the screening as per Dr. Ravi has mentioned. So Dr. Rajeev, like we see too many patients who are having multiple comorbidities also. Like if we talk about the diabetic patient, the patient must be having the comorbidities like hypertension, the patient also has retinopathy. So how do you address these comorbidities, or does your treatment plan or the prescription change if the patient is having other comorbidities or like?
Yeah, definitely. If the patient has
Or what are the
other
targets?
comorbidities, yeah. If the patient has other comorbidities, you have to be very aggressive because you cannot take the other comorbidities lightly. So the targets change. For a diabetic hypertensive, the target is 130/80, ideal target. Okay. Similarly, the other targets also change. The HbA1c should be around 7. Or if the patient is young, it can be lesser than that also, 6.5 to 7. If the patient is elderly, you can keep it 7 to 7.5. So the targets change because you have to be more aggressive so that the progression of the disease is not there, because multiple other factors are also playing the role. So as I said, the frequent screening is very important. I think we should make it a habit that on every visit, normally on an average, our patient visits in 6 months or 3 months, not before that. Even if at 1 month, they don't come back. So we should make it a habit that before every visit, whenever they come, urine microalbuminuria, UACR and EGFR should be there in every visit. And depending on the comorbidities, other tests should also be there, like lipid profile or the other tests which are required. So we have to be very aggressive. There should not be any inertia. Sometimes most of the patients, they say, my reports are absolutely normal, I have seen the reports and I'm not carrying the reports. So, but when you tell them that please show the reports, then you realize that urine MAU is more, UACR is more than 30, and then you tell them the importance of this. So I think frequent, monitoring is very, very important, and the targets are stiff when you have comorbidities.
True sir, मेरा यूरिया क्रिएटिन तो ठीक था सर, वो मेरा अल्ट्रासाउंड भी ठीक था, तो किडनी की कोई दिक्कत नहीं है मुझे.
Exactly, that's what this is the common.
This is the common statement which we hear in our OPDs.
And when you screen their previous reports, you find dyslipidemia, you find, they think LDL of 110 is normal. They think, UACR of 30 is normal. So that is how we have to go.
True, sir. So just continuing this, like if we, Dr. Setu, we are having some hormonal disbalances also in these diabetic kidney disease patients. So what all hormonal disbalances as an endocrinologist would you like to address, would you like to see or screen for, and how do you deal with the hormonal disbalance, or what are the what are the common hormonal disbalances which we see in these diabetic kidney disease patients?
So diabetic kidney disease usually have the similar kind of hormonal imbalances as a CKD. They really do not have any particular changes by the virtue of being a DKD. So whatever we screen or we ask for in patients with CKD, I would just say that. So subclinical hypothyroidism is a very common finding, and almost around 50 to 60% do tend to have it, and if required, we usually tend to treat them. We do not follow the usual guidelines that subclinical is not to be treated. In such cases, we usually err on the side of error and caution, and we tend to treat them. That's going to be the most common, and we don't question the patient for this. We usually do run the test for it. Rest, the other thing that we run tests for is looking at the bone health, because again, questioning is not going to help. We usually advise for a DEXA. We look at, we ask the patient for previous history of fractures. We get a vitamin D and PTH done, and calcium, phosphate, ALP. These 5 are required to assess the bone health, and is pertinent because almost 30% do end up developing them if the duration has been more than 5 years. So that's regarding the bone health. Rest everything, it's based on question base. So there is a male and female hypogonadism, so we usually question their cycles, we usually question their libido, their desires, particularly in male. And a very common cause of male hypogonadism is hyperprolactinemia. So CKDs tend to have some level of mild hyperprolactinemia, to the range of 50 to 70 nanograms per ml, and we do tend to treat them because they tend to improve the hypogonadic features. And if there is no hyperprolactinemia, then these hypogonadism can be treated by giving exogenous testosterone or OCPs in case of females. Then the other important ones would be about aldosterone. So usually if obese diabetic patients who are hypertensive, it's a good idea to screen for renin and aldosterone levels, because up till now we were under the impression that once a patient develops CKD, then screening for aldorenin is not relevant because it's going to be high renin. But 2 years back, Mayo data has clearly shown that the CKD with hypertension who are not controlled on 3 antihypertensives at least 2 and aldorenin once. So I would say that is also an important test that we can do at least once. And I think like you were saying, in the past 1 year I have picked up 2 Cone syndrome with just screening.
Yeah, that we were discussing off stage also. So thank you, Dr. Sethu. So we are okay, means we have to screen the patient. So Dr. Bansal, what in your opinion should be a treatment approach, or rather patient education approach? How do you educate your patient, or rather how in your opinion should we educate our patient regarding this DKD for the prevention of DKD, early diagnosis? So diet and advice to the patient as compared to for education, sir.
Yes, very important. See, our patients are, whenever we tell them that your kidneys are getting affected, so they become serious, because dialysis everyone is scared of. Nobody wants dialysis. So you tell them that you have to have a very strict glycemic control. Then you have to have a good diet control, and a proper diet communication has to be there, because there are a lot of questions about diet. And then frequent monitoring with simple tests like microalbuminuria and UACR, and adherence to the treatment and follow up to the treatment. So these are the 3-4 most important things which there are a lot of patients who are following this, and they are maintaining and they are improving also for years. They do not go on dialysis, but there are a lot of patients who do not follow this, and so the communication, I think, has to be there. You have to spend some time, at least in the first visit, and then subsequently, it is very simple.
True, sir. Means in our primary care setup, when we are in the OPD setups, we are to give time and explain the patients. So Dr. Dang, how do you ask your patients to follow? Means, like if I am a patient, my UACR is though not between 11 and 30, but slightly more than 30, sir. 11 and 30 पे तो बहुत सारे हो जाएंगे sir. Even अपन बैठे इनमें से भी कोई 2-3 निकल जाएंगे sir. So if it is above 30, so what will your approach be for me? Means like what would you advise? How frequently should I get the UACR done?
So if a patient has normal this thing, maybe yearly is also okay. But if a patient has UACR which is high, then it should be repeated. I would do it at 3 months. I know the guidelines say 3 to 6 months, but I would err on the earlier side, because albuminuria, micro or macro, whatever, is a sinister sign, and it tells that the whole vascular bed, the cardiac, the renal, the retinal, all are getting involved, and I would do it at 3 to 6 months.
So any treatment protocol would you like to change according to the UACR values, or what would be your treatment protocol for me, sir?
So I was listening to someone, he said SGLT2 inhibitors should be in the water stream of a diabetic patient. So SGLT2 inhibitors have to be there, ASARBs in the maximum tolerated dose have to be there. And I'll just, give me 1 minute. See, in 70s, the eGFR decline per year used to be 10 to 15 ml per year. And within 3-4 years, or 2 to 3 years, patient would reach end-stage kidney disease, and we could do nothing. In 90s, when the ACE inhibitors came, it came down to between 5 and 10. Now with SGLT2 inhibitors being added, the eGFR decline is between 2.5 to 5 ml per year in most patients. And with GLP-1 receptor agonist, we have to see how things move on. So all these 4 pillars have to be there on board in most of our patients, along with good blood pressure control, less than 130/80, and they say, I would still err on even better, 120/80 maybe even better. They say that the morbidity goes down, even the cardiovascular events go down. Between 120/80 and 129/88 or 129/84, there is an improvement if it is 120/80. So go for a good control of blood pressure, and of course statins, etc. have to be there. And lifestyle modification, very, very important. And dietary modification, protein restriction may not be that severe. Dr. Bhalla can correct me if I'm wrong. 0.8 to 1 gram, is that right? So 1 gram, that is the protein intake.
Thank you, sir. So, Setu, just to add on to what Dr. Dang has said, would you like to comment on these newer drugs? How do they help? Means like Dr. Dang had talked about the SGLT2 inhibitors, the GLP-1 RAs. So, according to a primary care physician, GLP-1 RA तो भाई sugar की दवाई है वो kidney में कैसे help करेगी? So, you would like to enlighten us about these newer drugs?
So SGLT2 inhibitors primarily work by reducing albuminuria. That's the primary mechanism of this. So SGLT2 receptors are present in the proximal convoluted tubule. It also, so when it is blocked, the pathways happen. There is a glomerular feedback, juxtaglomerular feedback, because of which even proteinuria tends to come down. So it usually prevents proteinuria, which further prevents glomerulopathy as well as tubulointerstitial pathies. So it primarily helps predominantly when, as we had already discussed, when there is albuminuria, it tends to work better, but even in the absence of albuminuria, it did show evidence, as was evident in the EMPA kidney trial. GLP-1 receptors, they tend to work at the vascular level rather than at the glomerular level, and they tend to provide a decline in the creatinine, decline in EGFR rather than prevention or reduction in albuminuria, because it primarily is acting at the level of vasculopathies. And the same goes with finerenone, sir. It acts at the endothelial level, also at the levels of tubular MC4 receptors at the collecting duct and the distal ducts. So it tends to act at both two pathways. So these are the different mechanisms. Yes, they are primarily started off as anti-diabetic drug, but now they've become more of cardiovascular as well as now renal drugs. So they're gonna be the next statins as everybody's talking about it.
So one more knowledge from your side, like I had heard in a talk that if the EGFR is less than 60, so you should be cautious in starting the GLP-1 RAs. What is your comment in that?
So, the caution word was probably because of the side effects. Because, sir, if, for example, if we take somebody who is on dialysis or somebody whose EGFR is less than 30, they anyway have some uremia, they anyway have some nausea which is there, and GLP-1 tends to exaggerate that. But as far as the guidelines are concerned, or as far as the safety threshold is concerned, even up till 30, GLP-1 can be used, sir, and they are being used.
GLP-1s can be used even lower than
that.
And we have to be cautious. We can use them, start low and go slow. And I would not agree with that comment, whoever made it.
Sir, your comments, Dr. Manoj?
Yeah, I think I agree. GLP-1 receptors can be used, so there is no contraindication as such. Only thing is the side effect which Dr. Setu has enumerated, because once the patient becomes symptomatically uremic, so they have a lot of GI effects because of uremia, and if you add GLP-1, they have more side effects. So that's the problem there. But it's not that it is not effective, but it works predominantly for the vascular. Even GLP-1 receptor has been best shown in atherosclerotic cardiac disease rather than the heart failure. So probably SGLT2 inhibitors, they act more on heart failure and prevent mortality because of heart failure, whereas GLP-1 receptor will prevent more because of ischemic cardiovascular events. So, and similarly, they also prevent the decline in GFR by working more on the vascular injury rather than the proteinuria or hyperfiltration injury.
So GLP-1s are an excellent drug, and we will see more and more usage in heart failure with preserved ejection fraction. We have data from STEP, HFpEF in diabetics and non-diabetic obese patients also. There was significant improvement in heart failure with preserved ejection fraction, and in years to come, you will see GLP-1 receptor agonists being used more and more for this entity also. Of course, we have to wait for 1-2 years. But this is the preliminary data.
So, Dr. Ravi, one question to you. जैसे हम लोग बोलते हैं, हम लोग physicians हैं ना, थोड़े से भीचू टाइप के होते हैं, inertia. एक और inertia होता है कि हम लोग एक हमें ये आप गाइड करें, means just give us a guidance when to refer the patient to a nephrologist, because we would not like to refer all our patients, because all the diabetic patients, either they may be having a cardiological problem or they may be having a nephrological problem or nowadays liver problem. So when to send the patient, because ये जो मैंने word use किया था भिंचू, this was a word which was used by one of our teachers. Stage से उतर के मैं बता दूंगा, everybody knows him. So he said that as a physician or a diabetes practitioner, you should not leave your patient till you are able to treat him. Till you are able to treat him. So when to refer such a patient to a
So
nephrologist?
I think you have given the answer itself. We all are physicians. I am also a physician. I am also practicing medicine. So I don't feel that all other practicing medicine people, they can't manage diabetic nephropathy. They all can manage diabetic nephropathy. It is information and practice and skill. With time, everybody learns, and everybody who's dealing with diabetic patients should try to manage diabetic nephropathy patients. But then there will be times where you will feel that probably it is not diabetic nephropathy. It is some other nephropathy or some other kidney disease. So what could be those signs? Suppose patient has RBCs in the urine. Suppose the creatinine is rising rapidly, is not getting controlled. Suppose the ultrasound shows some other findings. So in those cases where you are in doubt that it is not a diabetic nephropathy, you should definitely refer the patient to a nephrologist. Second is that if you feel that in certain situations, patient require further intervention, like patient require guidance for management of anemia, calcium phosphate balance, vaccination, these all can be done at physician level also. But if they are requiring intervention for fistula formation or further plan of, a further treatment of dialysis or transplant, in those cases patient should be referred. So I would say you judge your line yourself, that till what level you are comfortable. And obviously we all are upgrading our knowledge. So nobody, you can't say that you have to refer the patient. It's not like that. You have to manage till you feel you are able to help the patient. If you feel you can't help the patient, you can refer the patient.
Your comment, sir?
So very simple indication is when patient starts asking too many questions. So you should refer the patient to a nephrologist immediately, because you are not a nephrologist. And secondly, as he rightly said, if the patient is not improving, so you have to, at least, once you have to give the choice to the patient that please consult a nephrologist. And, we have seen most of the patients when we tell them to refer to, go to a nephrologist, they do comply, but they come back. That doctor has written these things, and now we can follow with you. So all the things are okay, so we can follow with you. So there is no harm in, referring the patient to a nephrologist given the choice, because the scenario is like that. And if the patient is asking too many questions, then obviously you have to.
Sir, a quick comment from all the panelists for a simple question. डॉक्टर साहब, मुझे जैसी डायबिटिक किडनी डिजीज हुई, फला डॉक्टर साहब ने कैल्शियम नोडोसिस और एक नेफ्रोसेव लिखी, आपने तो बताया नहीं है सर. So what is your comment, sir, starting from Setu? Short. कि डायबिटिक किडनी डिजीज होते ही should I write calcium, should I write taurine, should I write alpha keta drugs, or should I write calcium, should I write vitamin D, or should I write alpha calcitrol, or what should be done?
I think I haven't prescribed as many pills to diabetic kidney disease as I've cut down from the previous prescriptions. मतलब I think, and patients have always said that कि मतलब सर ये तो डॉक्टर ने बोला था कि यही किडनी को रोकेंगे. So it's very difficult to help them. Just one thing I just want to say, that calcitriol is a very, very abused drug in DKD patients. I would say that it should not be used in every DKD patient. There are very specified indications for that. So I'm just very scared with calcitriol. And one more thing I just want to add to sir's comment, sir. You've listed down all the three criteria for referral. Just one you missed, sir. That was nephrotic range proteinuria, because we do tend to see them a lot. And that really requires a nephrologist intervention. That's all, sir.
So my comment is that we have two scenarios. One is ideal situation and one is the real world or practical world. So you have to satisfy the patient. So I write these things, because if I don't write, the patient will not be satisfied, because these are not causing any harm to the patient. So as long as these drugs are not causing any harm, I try to satisfy the patient. So apart from the essential drugs, I add these drugs also.
So I would say follow the guidelines. I mean, I would not write, and I don't write. And as he rightly said, there are few nephrologists who write a lot of drugs, and I run away from them. Because unnecessary medication, burden on patient's pocket, is not recommended. I follow the guidelines, that is what I would say.
Dr. Ravi?
So actually I agree with Dr. Saab that burdening the patient with so many medicines is not required. But if you look into the physiology, like if a patient is developing renal failure, first thing what he requires is vitamin D, and he requires a control of metabolic acidosis, which can be subclinical initially, and even bicarb level can be normal. So early supplementation of little bit of bicarb and vitamin D is what I follow in these patients with early nephropathy. And as far as calcitriol, I think should be avoided until unless specifically indicated. Calcium supplements should be avoided until unless specifically indicated, because they have their own problems. And iron supplementation can be given if required for anemia and iron deficiency. So what is left is the question about N-acetylcysteine, taurine combinations. So are they useful, are they not useful? I think they are doubtful, and as a blanket treatment should never be used. So I don't use in my practice that way.
Dr. Singhal, sir? Sir, I would like to comment on this, sir. I have a very learned friend who had commented कि अगर मैं नहीं लिखता हूँ तो nephrologist लिख देता है, और अगर मैं लिखता हूँ तो nephrologist काट देता है. तो so this was the comment from one of my learned friends, and he is present here also, sir. So
I think what you said is we need to decide कि हम क्या practice कर रहे हैं, या हम खाली इसीलिए कर रहे हैं कि हम मैं नहीं लिखूंगा तो दूसरा लिख देगा, मैंने लिख दिया तो दूसरा काट देगा. I don't think that is the right philosophy, and one should not be guided by that philosophy. The few things which don't work, we know that. Protein restriction, for example, there is no question of restriction. Indian diet is so deficient in protein, most of the time you have to increase their protein intake and restrict their fat and carbohydrates. So protein restriction, there is no rule. Blanket treatment of soda bicarb, even nephrologists write it. Somehow I don't write it unless until the bicarbonate goes below 22. Generally, I don't write soda bicarb to more than 10% of my patients. Arginine, taurine, I have never written on my prescription. Keto analogs, I have never written on my prescriptions. Calcium, vitamin D, as Dr. Ravi has said, it's not a blanket treatment. Only if it is indicated for bone disease, you write it, otherwise no. So generally, there is no blanket treatment for you. When you deal with the patient, then you make a deal. Okay, these are the things which work. ACE, ARBs works. SGLT2 inhibitor works. Fenrinone definitely. Blood sugar control. As Dr. Dang has said, most of our patients are not controlled as far as blood sugar in blood. Who is responsible for that? We are responsible for that. So I think emphasize on these effective treatment where you get the incremental return. And hyperuricemia, I mean the moment uric acid goes from 6.4 to 6.6, it becomes bold and everyone writes febuxostat. Is there a data? No. Just because we have a medicine which can bring it down and we can show the patient, okay, now your uric acid is less than 6.4. Why unnecessary? And every medicine has a side effect. There is no medicine which doesn't harm. Even B complex may have some harm to the patient. So I don't see anything which is harmless. Even the food is harmful. It makes you obese. Very harmful. So I think one has to strike a balance and work for your conscience as well, rather than for a peer pressure or comparing with other people.
thank you, sir. And just in continuation, sir, any recent advances in either diagnosis or treatment which you could enlighten, sir?
No, I think a lot of it has been highlighted since morning. Most of the medicines which are already there, we have discussed. Few things was come up in the comment. For example, there is a lot of redundancy. So Fenrinone, as we have discussed, mineralocortical receptor antagonist. So we can give these antagonists to block the receptor, but now people are working on synthesis inhibitors. So if we block the synthesis of aldosterone, that is maybe the next step. So there are trials going on. It has not come to the clinical practice, but soon we will see. Then there are double blockers like ET receptor blocker. So there are blockers which can block angiotensin receptor as well as endothelin receptor. So they have been tried in non-diabetic kidney disease, but sooner I am sure they will also be tried in diabetic kidney disease. And then there are other things like gene therapy and other things which we have to see the light of the day. But I think most effective therapies are these 4 pillars which we have discussed since morning. So if we use these judiciously, I'm sure we can control a lot of these patients who have diabetic kidney disease.
So Dr. Setu, one crisp comment from your side, like obesity has been earmarked as the isolated marker of progression of DKD also and early DKD also. So any new thing in, like we all know that obesity has to be controlled, and once the obesity is controlled, then you can slow the progression of DKD also. Rather, some medicines have shown to bring out the patient from macroalbuminuria to microalbuminuria. So any new things in pipeline for these, like we have GLP-1 RAs.
Yes, sir.
So we have got some glucagon antagonists also.
Yes, sir.
Just
So
a small crisp comment on
just basically, sir, ADA 2023 was all full of anti-obesity drugs. They introduced 6 drugs in the form of phase 2 trials. The paradigm for obesity treatment is going to change in the coming 5 years. We have, like you said, we anyway have dual tirzepatide is already in the market. So it's a dual antagonist, and we have dual plus triple, which is glucagon. So we have retatrutide, we have stuvitide, we have so many drugs that are coming up. So I think obesity is going to change, and indirectly as obesity improves, the diabetes, the hypertension and the DKD is going to get managed pretty easily.
So there has been 2 bells from the organizer. So one single line crisp comment from all the panelists, sir. Start, Setu. Comments?
Comments.
Take home messages for our delegates.
I thank Ajay sir for managing it so well.
Yes, sir.
So I have a comment to make here that most of the conference, there is a difference between what we preach and what we practice. Ideally, that difference should not be there. That is one comment. Because on the dais, we say something else, and when we see the prescriptions, there's a lot of difference.
Disclaimer
There
is
was
that
a time about a drug, tenaligliptin. Everybody used to, on the dais, everybody used to, just say bad things about that drug. Useless drug. No need to talk about that. But everybody was writing it. So, this then ideal situation and the practical world.
True, sir.
Different.
You have pointed out very true statement, but there is a disclaimer that this talk is not sponsored by any of the companies, and you can say your own comments, whatever you want.
No. I'm not talking about, I'm just giving an analogy.
Yes,
Yeah, this is an analogy.
I think it was an excellent discussion. Thank you.
Thank you very much.
I want to make one comment is that there should not be communication gap with the patient. Like some patients, they fear coming back because either you have told them so much or they fear paying fee again, coming. So what I tell the patient is don't worry about the fees. At least come every 3rd day, 2-3 times. Initially because, you have to up titrate sugar and BP medicines. So that phase is important. So they should not be like, they should not run away and go and come after 2 months saying it is not controlled, doctor. Your BP medicine is useless, your sugar medicine. So initial communication, repeat visits. They will educate also and build confidence in the patient. So that is very important.
I think I would partially agree with Rajeev Bansal that what we say here on the dais, we don't do it in the practice. And let me just tell you, as a nephrologist, when we see patients who come to us with diabetic kidney disease and creatinine is 4, 5, 6, many of them would not have their albuminuria checked or have serum creatinine checked. Right. So I think we should feel that these are very important tools, should be used more often for screening, and once we find them as abnormal, we should pay some attention to it and say titrate our treatment and try to because there are effective treatment. At least on that part, most of us are convinced that now there is effective treatment which has brought down the deterioration of GFR from 10 ml to 2 ml and maybe to 1 ml per year in future, which is a normal aging phenomenon. So there are effective treatment for kidney disease, and we should use them more often. And that can only be used if we screen these patients and start this treatment in early stages.
Thank you, sir. Dr. Makkad?
I think I'll go back to the SGLT2, not a controversy, the usage pattern. So we have an endo here, we have 2 physicians, and we have 2 nephrologists, and SGLT2 seems to be, one of the big pillars of, renal patients. So what is, as a nephrologist, as a, a physician practicing diabetology and as an endo, what is the threshold in your practice with regards to using SGLT2 inhibitors? And when I say threshold, I'm talking about two, one is of course the albuminuria, or the level of albuminuria, whether it is micro, macro, and the level, and the GFR. Because, there's always a risk of, the ketoacidosis with SGLT2 inhibitors and so on and so forth. So what is your, as an endo, what is your threshold? As a physician, what's your threshold? And as a nephro, what's your threshold?
So, sir, I think the guidelines for this are, I'm just going to be very brief. The guidelines are very clear. SGLT2 inhibitors can be used for glucose reduction or for the management of diabetes reduction. It's very effective with an EGFR of more than 30. So that comes with when we're managing diabetes. When we're coming to the management of DKD, albuminuria reduction occurs till an EGFR of 20. There have been different trials with different GFR thresholds for albuminuria reduction, but KDIGO 2024 and 2023 had very clearly said that this is a class effect and they have made it 20. So up till an EGFR of 20, there's going to be a significant albuminuria reduction with the usage of SGLT2 inhibitors. Earlier, when you with an EGFR of 30 to 45, when we initiate SGLT2 inhibitors, in the early 2 weeks, you're going to see a decline in an EGFR, which is going to be very normal, which is nothing to be scared of, because this early decline means that later on, the rapid reduction is not going to be there. And creat reduction will occur early on, but with an albuminuria reduction, over the years, it's going to settle down.
So let me put my question in a different way. So let's say there's a patient who, let's say 48-year-old diabetic patient, diabetes for the last, let's say 10 years, maintaining his albuminuria between 10 to 11, 10 to 15. Now he comes to you with an albuminuria of 20. Would you start an SGLT2, keeping everything else normal?
Yes, sir. No, ACE ARBs are going to be there.
So he's already on all these drugs.
All these drugs, yes, sir. SGLT2.
So would you start an SGLT2?
Yes, sir.
Okay. What about physician? His albuminuria
Definitely, with the new cutoff of urine microalbuminuria of 10, and if the MAU is increasing, say you are saying 2 times from 10 to 20. So I would like to have a concern, and I would like to, if the patient is already on ACE ARBs, I would like to add another drug, maybe SGLT2, maybe. So I think yes.
Okay.
Add one more thing, to repeat the albuminuria again just to confirm whether it's rising or not. It has to be.
Not only urea, I would like to give SGLT2 inhibitor earlier on, because we have so much data that patients who had eGFR even between 60 and 90, their progression and worsening of kidney disease was much less. They had less heart failure in years to come. And we know that in today's era, all the complications are coming much earlier. You get heart failure within 5 years, you get kidney disease within 5 years, sometimes you get kidney disease at presentation. So I think anyone who can tolerate SGLT2 inhibitors, they should be on board, maybe immediately after metformin in most of our diabetic patients.
Nephro?
So, yeah, I will definitely want to treat everybody with SGLT2 inhibitor. Every kidney patient, because it has been proven, even in DAPA CKD, that non-diabetic kidney disease also you can use SGLT2 inhibitors. But only problem is that of the side effects, of the tolerance, as Dr. has pointed out, should not combine with diuretics, can get dizzy, postural symptoms, dehydration. Whenever patient is admitted, you should stop it, because they can land up with euglycemic ketoacidosis.
Yes.
And when the patient is not taking diet, that time I should be very careful. So you have to monitor the side effects.
True.
That's also. Otherwise, it's a very beneficial drug.
Fair.
I would want to use in all patients, and UTIs. So
I think you talked of threshold. So if you look at the guidelines, even if you talk of guidelines, these are the first line medicines for diabetes. Same way ACE inhibitors, ARBs are now first line medicine for hypertension. So anybody who has diabetes or hypertension, he should be on ACE ARBs or say SGLT2 inhibitors, irrespective of their GFR and proteinuria. The indications now are widening. For EMPA kidney, for example, including patients who had no microalbuminuria. So when the albuminuria is less than 20. And if you believe the cardiovascular benefit of these medicines, then irrespective of renal disease, these patients should be on these medicines. Why not? Only precaution would be when the GFR is less than 20. So whenever we start these medicines, there is a fall of GFR of approximately 25 to 30%. So their creatinine will go up from 4 to 5 on next visit, and that may create some sort of a panic or alarm in the patient. So that's where I probably would not start it, but if I follow these patients on 2-3 visits and once I have a rapport, at least I can explain these issues to the patient and may start it in a lower dose. If the patient is already on SGLT2 inhibitor, irrespective, till they go and on dialysis, we continue these medicines.
Fair enough.
So starting at that point may be a little tricky, but it can be started if you have a good rapport with the patient. Otherwise, I don't have any threshold. So any patients, I would start these medicines.
Perfect. Thank you.
Thank you very much. And I thank all my panelists for such a descriptive description of the DKD. So with the note that patient education, early approach and intensive approach, we can all thank our panelists. Thank you everyone. Yes, sir. Sir, usually
it is calculated with three parameters. One is the age, gender of the patient, and serum creatinine. So they use CKD EP formula, and that's all, because they have the age of the patient, they know the gender of the patient, and they know the creatinine, and that's all. Sorry? No, sir. Weight is required for Cockcroft and Gault. This CKD EP, which is based on the population study, MDRD study, where they have a large number of populations. So initially there were 4 parameters, then they removed the race from that. So we take these 3 parameters and calculate eGFR.
And it has been mentioned and mandated by the RSSDI guidelines also that in the future all labs will be having eGFR in their KFT reports. So that's why some of the labs like the standard labs of Max, Agilus, Lals, they do mention eGFR, sir, in the KFT, sir.
There are eGFR calculating apps also on the Play Store. You just have to put the patient's age,
आप एक
gender,
calculator करके
and
app आता है, sir.
creatinine.
So they have these 3 data, so they can calculate eGFR and report it. And ideally, now, as he said, there are guidelines to report the eGFR, just to make them more aware. So whenever the eGFR is less, in fact, only thing which I still feel is lacking is they mention like less than 59 is abnormal, whereas they should mention that more than 90 should be normal. So we still miss that 60 to 90 window in these. So that's the only missing in that report.
A very small question from my side. Sorry for the delay further. The link between asymptomatic bacteriuria and SGLT2 inhibitors. Suppose we plan to start a patient on SGLT2 inhibitors, we get the urine routine done, there is asymptomatic bacteriuria, first situation. And the second situation, the patient is already on SGLT2 inhibitors, as the matter of routine we get it done and we find asymptomatic bacteriuria. A very short take, please.
Asymptomatic bacteriuria should be treated only in certain conditions. One, you should not screen for asymptomatic bacteria. Ask for a urine culture only if the patient has symptomatic urinary tract infection. If patient is not symptomatic, don't ask for urine culture report. Except in few situations like pregnancy, where you need to screen them. If the patient is planned for some urological procedure, that's where you need to screen them. Otherwise, don't ask for urine culture.
So, sir, in such a patient, will we confidently start SGLT2 inhibitors? And if such a patient is already on SGLT2 inhibitors, will we continue them?
Say, urinary tract infection, one should not start them on SGLT2 inhibitors. You treat urinary tract infection. Unless until they have a recurrent urinary tract infection or some predisposition for UTI, then probably SGLT2 inhibitors would not be a good medicine. But if they just have one freak incidence of urinary tract infection, I would restart SGLT2 inhibitors in these patients.
Thank you, sir.
If a patient is on SGLT2 inhibitors and gets asymptomatic WBCs 10, 12, I would ignore it. I would give them more water and,
Right, sir.
you know.
Thank you, sir. I would request the dignitaries to proceed for the felicitation area, and I would request Dr. RPS Makkad to for the felicitation.